Okay, so again, welcome everybody. My name is Michel Long. I'm the program manager at the Canadian Hemophilia Society. I'd like to welcome you to this video conference. Bonsoir, mon nom est Michel Long. Je suis le gestionnaire de programme à la Société canadienne de l'hémophilie. J'aimerais vous souhaiter la bienvenue à cette visioconférence. So this video conference will last about an hour and a half, maybe an hour, 40 minutes. When you have joined the conference, you are automatically muted. So I would ask you to stay muted. We will be allowing you to ask questions live towards the end of the presentation. So this conference is being recorded because we plan on putting it up on our website for eventually people who are not able to attend live to view it, and also to serve as an educational tool. I would also like to thank our industry partners, Roche, Octopharma, and Novo Nordisk, who have been supporting us in our work with inhibitors. The webinar actually is made up of questions that many of our members have been asking us over the last year, and more specifically, questions also that participants have sent to us prior to this evening. So the presenters are going to try to answer most of the questions within the framework of their presentation. So hopefully your question will be answered. If not, certainly feel free to answer the questions during the question period. Francophone participants should be aware that this presentation is going to be all in English. However, during the question period, you can ask your questions in French, and they will be answered in French. Alors pour les francophones, toutes les présentations vont se faire en anglais. Toutefois, durant la période des questions, vous allez pouvoir poser vos questions en français et on va y répondre en français. What's important to keep in mind is that we're going to try to answer the questions, the general questions that people are asking. This cannot be considered like a medical consultation. So any specific questions to your own situation cannot be answered during the course of this webinar because our presenters, even they are healthcare professionals, they don't know your background or your medical records, and so they can't really do that during this webinar. So we would ask for you to contact your healthcare provider should you have any questions specific to your own situation. So this conference is done in meeting mode, not webinar mode, so that we can speak to one another during the question period. So we also would like it to be interactive. So we will do that at the end. So you're normally muted upon entry, and we would ask you to stay muted until the question period is open. And questions will only be taken at the end, not after each presentation. And you can also type your questions in the chat box. That will become available during the question period. And of course, you'll be able to ask your questions verbally as well. And as I mentioned, this webinar is being recorded. So you'll see we are using Zoom as a platform. So you'll see at the bottom of your screen, or perhaps if you're on a different platform like a phone or a tablet, it may be not evident right away. But if you put your cursor at the bottom of your screen, you should see the bar appear at the bottom of the screen. And you can click to join the audio or the video, and you can turn off your video if you wish by clicking the button video, or the audio, you can mute and unmute yourself. If you click the button that says participants, you will be able to see all the participants. And of course, click the chat button to see the chat. And you'll see there's a special icon here that says reaction. And if you click on it, you can give a thumbs up or give any other reaction during the course of the presentation. And also in the participant window, you can actually click on certain indicators like go faster, go slower, and so on. The participant chat box looks a little bit like this. And so you can type your questions in the lower box where it says type message here, and then you can just click send and we'll receive your message. Finally, you'll see that you have the possibility to have speaker view or gallery view. We recommend that you click on speaker view at the top right corner, and this will allow you to see whoever is speaking when we turn on the speakers. So this is the agenda that you've seen when you registered. We're planning on a meeting of about an hour and a half, an hour 40 minutes at the maximum. We have about nearly 60 participants that registered for this. So we decided to add maybe an additional 10 minutes at the end. So it may be an hour and 40 minutes if people have lots of questions to allow a little bit of more time. So without further ado, I would like to invite Dr. Georges Rivard to unmute himself. He will be our moderator tonight, and he is also the person who will be doing the first presentation. So Georges, can you come on?
Yeah, can I have the first slide, please?
Yes, I'm gonna put that up right now. Hold on here.
I don't have the slide on now. Eh?
There we go.
Can you put? Oh, thank you, Michel. Good evening, everyone. My presentation will address some issues raised by some of you in the audience about basic questions related to inhibitors. This will serve as an introduction to subsequent presentations, which will be more practical and specific. Next question. Next slide. What is a factor VIII inhibitor? Just right on up front, I'd like to say that every time I talk about factor VIII, that can also apply to a factor IX, as most of the general principles that have to do with inhibitors are somewhat similar with 9 and 8. So for the sake of time, I will always talk about factor VIII, but it could also mean factor IX. So what is a factor VIII inhibitor? This is an antibody that is produced against factor VIII by a subject with hemophilia A, whose immune system perceives factor VIII as foreign to his own body. Might be interesting to know that a substance to which a human fetus is exposed is perceived as foreign if the exposure takes place after 20 weeks of intrauterine life. Before that time, any foreign material could be perceived as self. Next. Are there different types of factor VIII antibodies? Basically, there are two types of antibodies. Those that are called neutralizing, they inhibit, hence the name of inhibitors. They inhibit function of factor VIII. They are tested by the Bethesda assay. Done neutralizing, they increase the elimination of factor VIII from the body. They are tested by ELISA assay. Next. Inhibitor development. Who develop inhibitors? Basically, subjects with hemophilia A who are exposed to factor VIII, which is perceived as foreign by their own body. Next. How often do hemophiliacs develop inhibitors? Between 10 to 30% of subjects with severe factor VIII deficiency, and between 2 and 10% of subjects with severe factor IX deficiency. Next. Why do people develop inhibitors? Well, there are genetic and environmental reasons for up or down regulation of inhibitor development. Next. The development of inhibitor, why is it? For genetic reason and for environmental reasons. For genetic reason, family incidence, racial incidence, type of factor VIII gene mutation. Next. Family incidence, a paper published by Swedish investigators, 388 hemophilia A subjects The overall incidence of inhibitor in this group, 32%. If someone has somebody in his family who has inhibitor, the likelihood of developing an inhibitor is 48%. Now, if this someone in the family who has an inhibitor is the brother of the newborn with a severe factor VIII deficiency, the likelihood of developing an inhibitor is 78%. That means that there are other reasons than just the factor VIII mutation that are responsible for inhibitor development. Now, racial reasons, if your genetic background is Black African, well, you have twice as high a risk of inhibitor than if you are Caucasian by ancestry. Next. Now, about factor VIII mutations, one has to know that there are at least 3,000 different mutations of the factor VIII gene that are associated with hemophilia. Now, in terms of the prevalence of inhibitors amongst the people who have these different types of mutation, this can be summarized as in this slide. For instance, if one has a type of mutation that is called missense, roughly 5% risk of developing an inhibitor. If the mutation that is at stake is a large deletion or an insertion, roughly 40% risk of developing an inhibitor. Next. Now, talking about environmental reasons, indication for first treatment, age at first treatment, type of product used. Next. And indication for first treatment. There are several papers on this. I selected one of our study that was done between 2005 and 2010, thanks to the wonderful collaboration of the hemophilia nurses of all hemophilia treatment centers in Canada. We were able to recruit roughly, 100% of the people with hemophilia born in that period of time. Altogether, 99 cases. Now, we are here presenting the risk of inhibitor development for those who were first exposed to factor VIII for prophylaxis, 0. At the other end of the scale, those who were first exposed to factor VIII for hemarthrosis or intracranial bleed, roughly 70% risk of developing an inhibitor. Next. Age at first treatment. This is still a very controversial issue, but since there are many studies on this issue by very good centers, this is still worth mentioning. Here happens to be a study from the Dutch group, 81 severe hemophilia VIII pups, cumulative incidence of inhibitor at 100 exposure day. First exposure at less than 6 months, 33%. At more than 18 months, in this particular study, no persistent inhibitor. Next, type of product. Also an issue that was responsible for many very active debates and arguments. And here is a study, not a study, but a publication that puts together 15 different studies that look at the inhibitor development as a function of the type of factor VIII used. With the gray bars, one looks at people that have received recombinant products. The white bars, the people who have been treated exclusively with one single plasma-derived product. The bars speak for themselves. The type of product used, well, the best study on this is certainly the one from the Italian group of Floral Pivenzi and Pierre Manucci, 251 minimally treated patients. Cumulative incidence of inhibitor, roughly 27% with plasma-derived factor VIII and 45% with recombinant factor VIII. Next. Thanks. The next speaker is Manuel. Manuel, your turn.
Well, thank you, George, and welcome to all of you tonight. And thank you to the Canadian Hemophilia Society for the invitation to have me speak as well at this. I have a lot of slides, but they're very short slides. So Michelle, you'll have to be quick to move them along with me. So what I'm going to talk about in the next 10 minutes is how patients with inhibitors have been historically managed and what has changed now. Next. So when patients develop an inhibitor, of course, they can no longer use factor VIII to treat or to prevent bleeds. And as you can see, we're focusing this presentation on inhibitors to factor VIII, but really the same thing could be said to a certain degree in patients who develop inhibitors to factor IX. So these patients still are faced with the question of how do you treat bleeds if they occur in these patients? How do you prevent bleeds? And ultimately, should we try to eradicate the inhibitors? Next. What makes it even more difficult is that this is the usual inhibitor patient, or at least when they develop an inhibitor. They're very young. They tend to be 1, 2, or 3 years of age, the vast majority. Now, of course, we don't always get rid of the inhibitor. And so, of course, there may be patients who are 20, 30, 40, or 50 years of age with inhibitors, and maybe they're part of the audience of tonight's webinar. Next. Now, how do we treat bleeds? Well, we've had two, what I now call old agents. And I call them old agents because they've been around for over 25 years in both cases. So we've had APCCs, which stand for activated prothrombin complex concentrates. And there's only one, and it's also known as FIBA. And we've had recombinant factor VIIa, which in Canada is known as niastates. But both of these need to be given intravenously. And as I mentioned, most patients are very young. So you can see those two little hands there. And if I asked you, do you see any veins in those hands? And I would say that I don't see any veins. In contrast, if you look at your own hands right now, I bet you all of you could see veins in your own hands. So this makes it very difficult. Next. So as a result, what we've generally had to have done in the past, in most cases, is we have to put in a port. And a port has been a necessity when patients develop inhibitors. And although this little child, and this was just from Google, so it's not my own child, that's why I can show you the face. This child seems to be accepting it very well.
Hello.
We lost the sound, Manuel. Can you? Okay.
Manuel, did you mute by mistake?
I think he's frozen.
Okay, Manuel, you want to try to log back in? And we'll wait for about 30 seconds. Sorry, folks, for this technical difficulty. Hopefully, we'll resolve it fairly quickly.
Do you hear me again?
Yeah, you're back.
Yeah.
Sorry about that. I don't know what happened there. I guess it was my internet. Can you just go back, Michelle, and keep going back? Okay, stop there. So, so patients needed ports, have needed ports in the past when they've developed an inhibitor. Next. So as I mentioned, we can treat bleeds in patients with either of these two bypassing agents. Next. They both have advantages and they both have disadvantages. In the case of FIBA, its advantages, which are shown in green, is that it lasts longer in comparison to recombinant factor VIIa. It can be given every 6 to 12 hours. Its disadvantages are that it is plasma-derived. It is a much larger volume than niastase. It takes 30 to 45 minutes to give, although we know that some patients give it faster. It should not be given with tranexamic acid, and it does contain some factor VIII, which may be a problem before starting ITI. Next. In the case of niastase, its advantages are that it is recombinant, it's a small volume, it can be given in 2 to 5 minutes, and it can be given with tranexamic acid, but it doesn't last very long, and it needs to be given as a result more frequently than FEBA. Next. One of the questions that people ask is, which is more effective? And there's been a number of studies that have looked at that, and the bottom line to these studies is that there's really no difference in effectiveness between the two products. Next. But which is more convenient? Now, in the case of FEBA, it takes 30 to 45 minutes to administer, but to treat a bleed, 1 dose is usually enough. In the case of niastase, you can give it much more quickly in 2 to 5 minutes, or even less, in 1 minute. But you usually need 2 or 3 doses to treat a bleed, although you could potentially do it with a higher dose. Next. So the bottom line is that neither of these is very convenient to treat a bleed. And it's also not very convenient for prophylaxis, which I'm now getting into. So next. So to treat bleeds, we've had 2 old agents. Both are effective. They can treat bleeds, but they're not very convenient. Next. What about preventing bleeds? We all know that we can't simply just treat bleeds and allow patients to have bleeds. We have to prevent them. So both of these 2 agents can be used for prophylaxis or the prevention of bleeds. Several studies have shown that if you give FEBA every other day, like shown here, Monday, Wednesday, Friday, etc., that you can prevent bleeds. Next. If you give niastase, here you pretty well have to give it every day. You can prevent bleeds. Next. But you don't prevent all bleeds with these. Studies have shown that you only prevent 50 to 70% of bleeds with prophylaxis with these 2 agents. So a lot of effort and a lot of cost, and the return is not so good. Next. So neither of these 2 agents is very effective or very convenient when it comes to preventing bleeds. Next. And so the question then becomes, should we try to eradicate inhibitors? And in general, we should try, since life with inhibitors is not very good. Patients with inhibitors will develop more joint disease and will have a much greater risk of death. So up until now, the answer to this question, should we try to eradicate inhibitors, is next. Okay, next is absolutely, we should. Now, what is immune tolerance induction? Is it a frequent and regular exposure to factor to make the person gradually tolerant of factor, very much like allergy shots, except allergy shots are often given once a week. This generally needs to be given daily. Next. So if I was to start a patient today on ITI, as you know, today is November 2nd, and all those little red things at the bottom are days in which a patient would need to receive factor. Remember, this would have to be intravenously. Next. They would have to continue on ITI, daily ITI, for a long period of time before we can expect that this would work. And it doesn't always work. Next. It would have to be given intravenously every day into a port like that. And after all of this, it would still only be successful in 60 to 70% of the time to try to eradicate or get rid of the inhibitor. And it might take, I'm only showing you about 10 months worth, but it could, or maybe 12 months, but it could actually take 1 to 2 years of doing this every single day. Next. But until recently, if a patient developed a high titer inhibitor, this is what we did, because despite ITI being very hard, being very expensive, and not always being successful, the alternative of not getting rid of the inhibitor was very bad. Next. So in the past, the question was, should we try to eradicate inhibitors? And the answer to that was absolutely we should. Next. But now you're going to hear a lot about, in the next talks, about Emicizumab. This is a subcutaneous drug that can be given once a week, once every 2 weeks, or once every 4 weeks. And it's given subcutaneously. You don't have to find a vein. Next. Will it change how we treat bleeds in patients who develop inhibitors? No. We will still rely on the two old agents that we've had, FIBA and recombinant factor 7A, although FIBA should not be used with Emicizumab. There's enough data to show that that combination is actually very risky. But the good thing is on Emicizumab, patients have much, much less bleeds, such that you generally seldom need to use these agents. Next. Will it change how we prevent bleeds? Absolutely. Emicizumab is clearly a very effective and convenient prophylaxis agent. You're going to hear a lot more about that. And so really there's going to be no reason to use FIBA or niastase for prophylaxis. And next, and I think my final slide, should we still try to eradicate inhibitors? And I'm going to come back to that much later on in about 40 or so minutes from now. But I would say that arguments can be made either way, given that we now have Emicizumab. And next, and I think that's it. And I thank you all very much. And this will now move on to Dr. Jerry Teitel speaking. And I will be back in about 40 minutes from now. Thank you very much.
Jerry, welcome, you're on.
Thank you, George, and thank you to Michelle and the CHS for letting me be part of this meeting. You know, one thing I'll say at the beginning is you're going to hear a lot of repetition tonight, which I think is a good thing. I need a lot of repetition to be able to assimilate data. So I don't apologize if some of the things you hear are going to be repetitive. So I'm going to talk about Emicizumab. What is it? And can it help patients with inhibitors? Well, Manuel's already told you the answer to the second question, but I'm going to give you a little more detail. So the next, oh, sorry, I was trying to change the slides. Next slide. Thank you, Michelle. So what are the remaining challenges that in managing bleeding in hemophilia patients with inhibitors? So why do we need to worry about inhibitors? And some of the explanations are shown here. Even though we've had bypassing agents that Manuel showed us in his talk for many years to treat bleeding, inhibitors make treatment of bleeds less effective and less predictable. Prophylaxis, as you heard, for patients with inhibitors is not very successful. Joint damage progresses more rapidly in patients with inhibitors than those without. Treatment of bleeds in inhibitor patients can't be monitored by lab tests the way we do with in patients without inhibitors. Treatment of bleeds is more expensive in patients with inhibitors. Surgery becomes riskier in patients with inhibitors. And in those small number of patients who have mild or moderate hemophilia who do develop inhibitors, they generally become severe hemophilia patients, which is bad, and their mortality rate increases as well. So there's a lot of problems that we're still dealing with in patients with long-term inhibitors. Now, before talking about Emicizumab and what it does, I'm afraid I'm going to have to tell you a little bit about the way the blood clotting system works. Next slide, please. Thank you. So the role of factor VIII in coagulation. So this is a simplified scheme showing some of the clotting factors. So factor VIII, shown circled on the left, works along with its partner, factor IX. The little a stands for activated, so that's activated factor IX. So basically, factor VIII supports factor IX in activating the enzyme shown at the top, which is factor X, and activating it to a form called factor Xa. And the ultimate result shown on the right-hand side is the formation of a fibrin blood clot. So that's the way a normal coagulation system looks. And if you have hemophilia, you will have factor VIII. If you have hemophilia A, you'll get factor VIII concentrate that will replace that factor VIII. Next slide. What happens in a patient? Next, please. Michelle, can we have the next slide? Thank you. How do we treat patients with inhibitors? Well, inhibitors block the factor VIII, as Dr. Rivard said in the first presentation. So if you don't, I think you went over 2 slides. Can you go back one? Thank you. There we go, that's the one. So patients with inhibitors, the inhibitor blocks factor VIII. As a result, factor VIII is not there to support the role of factor IX. As a result, you don't get activation of factor X, and ultimately you don't get good fibrin clot formation. So what have we done in the past to treat patients with inhibitors? Next, we've used bypassing agents. One of the bypassing agents is niastase, factor 7A. That's shown in the box on the upper right. Factor 7A will activate factor 10 directly without the requirement for factor 8 or factor 9. It bypasses the deficiency, bypasses the inhibitor. The other bypassing agent is FIBA, which is an APCC, and it contains many different proteins, but the real action of FIBA consists of prothrombin, which is also known as factor 2 on the left, and factor 10A. And those together also are sufficient to lead to fibrin clot formation, thereby bypassing the inhibitor. Now, next slide. Treatment of hemophilia with inhibitors with Emicizumab is shown here. So we've got the inhibitor that's blocking factor 8, shown by the X. If you have Emicizumab, Emicizumab basically takes over the role of factor 8. It functions then to support the role of factor 9 in activating factor 10. Now, Emicizumab is a different protein. The inhibitor doesn't recognize Emicizumab. So even if the inhibitor is there, you've still got a factor 8-like activity in your blood. So is Emicizumab then a replacement for factor 8? Well, it's not exactly factor 8. Next slide. So what are some of the differences? This shows in a cartoon form what Emicizumab does. So it brings together factor 9, which is the enzyme in the reaction, and factor 10, which we call the substrate. That is, that factor 9 acts on factor 10. It brings them together on that surface, and that surface is actually a fatty layer on a cell surface. So it's doing the same thing that factor 8 does normally. So is it factor 8? Well, it's not. So the next slide shows some of the differences between Emicizumab and factor 8. First of all, Emicizumab is only about a tenth, a little less than a tenth as potent as factor 8 in supporting factor 9. So it's a fairly weak cofactor for factor 9, but we know it works very well. Secondly, Emicizumab, as Dr. Carcao already mentioned, is used only for prophylaxis, not for treating acute bleeds. The next point is that the presence of Emicizumab in the blood interferes with some of the coagulation laboratory tests that we do, including standard assays for factor 8 and factor 8 inhibitors. Now, that's not a problem day to day, but in some situations that may lead to some difficulties or some confusion, particularly if someone with Emicizumab appears at a hospital that is not a hemophilia treatment center. Emicizumab has a very long half-life, in fact, close to a month, about 28 days half-life, which means that even after 6 months after you stop treatment, there is still going to be detectable Emicizumab activity in your blood. Very long persistence in the circulation. As you know, factor 8 has a much shorter half-life, and that's why people without inhibitors have to take factor 8 2 or 3 times a week. And Emicizumab, importantly, is given subcutaneously, not intravenously, as for factor 8. Now, this is a meeting about factor 8 inhibitors, even though Emicizumab is approved and is used in many countries for treating people even without inhibitors, but we're focusing on inhibitors today. So the next slide shows some differences between Emicizumab and the bypassing agents. Michelle, next slide, please. So how does Emicizumab compare with the bypassing agents niastase and FIBA? And I'm grouping the two of them together. As Dr. Carcao has already told you, the two of them work pretty much equally well. So first of all, treat active bleeding, Emicizumab, no. Bypassing agents, yes, which means that if someone on Emicizumab with an inhibitor does have a bleed, whether it's traumatic or spontaneous or surgical, they're going to need treatment with bypassing agents. What about efficacy for prophylaxis? Emicizumab is an excellent prophylactic agent, and I'm going to show you the data in the coming slides that speak to that. And as you've already heard in the previous talk, the bypassing agents can be and have been and are being used for prophylaxis, but if you have to describe their efficacy in one word, I think that word would be poor. They're not effective. They're better than nothing, but they are not very effective prophylactic agents. Certainly nowhere near as effective as factor 8 or factor 9 in hemophilia patients without inhibitors, and not as effective as Emicizumab. Laboratory monitoring, we can't monitor we can't easily monitor either emicizumab or the bypassing agents. The half-life in the blood, as I told you, emicizumab has a very long half-life. The bypassing agents are short. Niastase, only a few hours, 2 or 3 hours, a little bit longer for FIBA, but they're both relatively short half-lives. Subcutaneous administration, emicizumab, yes. Neither of the bypassing agents can be used or has been used subcutaneously. It's possible that there may be some variations of factor 7A that could be used subcutaneously, but certainly not available clinically. What about safety? All these drugs really have a good safety margin. Any drug that we give that's a potent drug to support blood clotting has the risk of causing thrombosis, which is undesirable blood clot. It's rare when any of these drugs are used as directed, but it can occur. And as Manuel already mentioned, we tend to avoid using emicizumab along with FIBA. There is certainly a risk of thrombosis when FIBA is used in high doses or repetitively in a patient who's got emicizumab. It can be used safely in modest doses, but because of that risk, we tend to avoid it altogether, and we rely more on niastase to treat breakthrough bleeding in patients on emicizumab. So the next slide, please. So I'm going to talk in the remaining time now about the clinical trial results that led to the approval of emicizumab and the enthusiasm we have for its use now. And the studies I'm going to review, which were named by the sponsor as the HAVEN studies. HAVEN might stand for something. If so, I can't remember what it stands for. But what I'm going to, and there were a series of HAVEN studies, and I'm going to focus on HAVEN 1 and HAVEN 2, as again, this is an inhibitor meeting, and that's what we're interested in tonight. And HAVEN 1 was a study of adolescent and adult hemophilia patients with inhibitors. And HAVEN 2 was a study of children with hemophilia A and inhibitors. And by the way, I don't think I've mentioned this earlier, but emicizumab is a drug that can only be used in people with hemophilia A, not with hemophilia B. Remember, its role is to support factor 9. So it takes over the role, it simulates the role of factor 8. So it's only useful in patients with factor 8 deficiency. So first of all, let me talk a little bit about HAVEN 1. The next slide, Michelle, I think I've only got one slide to review the results of the HAVEN 1 trial. And it shows very, very nicely the main results. So this is a study in adolescents and adults. And this was a randomized trial. So patients were randomized, these are inhibitor patients, 12 and over. They were randomized to receive either emicizumab prophylaxis or no prophylaxis. Now, no prophylaxis doesn't mean no treatment. It means their regular treatment with bypassing agents as needed. And if you look at the two groups of bars on the left, labeled as group A and group B, so this is the emicizumab prophylaxis versus the on-demand treatment with bypassing agents. And the bars represent the number of bleeds, not the actual number of bleeds, but the bleeds annualized out over a 12-month period. So how many bleeds would they have in a 12-month period? Because the study was less than a full year. So this is after 20 weeks on the assigned regimen. But if you look, for example, at the blue bars in group A and group B, the blue bar shows all bleeding events in patients on emicizumab, and you can see the number there is 5.5, so it's annualized bleeding rate of 5.5. Compare that to 28.3 for the patients who were treated with their usual treatment, about a 5-fold difference. Each of the bars in those two groups is much lower in the emicizumab than in the non-emicizumab group. So the second set of bars refers to bleeding events that were treated with bypassing agents, because some of these bleeds may have been very minor and were not treated. The next set of bars shows spontaneous bleeds that were treated. Then the next set of bars, the orange or gold colored bars, treated events of joint bleeding, and finally target joint bleeding. So all the bleeds were much less in the emicizumab treated group. Now you'll notice the number in group A was 35 patients, and in group B was only 18. I told you it's randomized, but that was deliberate. This is was referred to as a 2-to-1 randomization schedule. So there were twice as many patients in the Emicizumab group. So that was the main results of the Haven 1 trial. By the way, I didn't focus on group C. That's another subgroup of patients who had been on prophylaxis with bypassing agents before they went on the Emicizumab. So there's no comparison here. So this is just another group on Emicizumab prophylaxis of 49 patients. And you can see that their bleeding rates look very similar to group A. So A and C are both given Emicizumab prophylaxis, group B, no prophylaxis. And the differences are very clear to the eye, and they're very clear to the statisticians too. Emicizumab was statistically much better in terms of preventing bleeds. Now, the next slide, a few slides about Haven 2. So this is the study in children, so age less than 12 with inhibitors. This was not randomized. So these children were all given Emicizumab. I think it was 65 or 68 children, as I recall, in this study. So a good number of patients, young patients with inhibitor antibodies. They've not been tolerized, so they're not getting factor VIII concentrate. They've still got their inhibitor. And they were treated during the course of the study with weekly Emicizumab. And this shows their bleeding rates. And if you look at the table on the left, treated bleeds, this is again annualized, treated bleeds considerably less than 1, less than a half per year. Now, in other words, that's like 1 bleed every 3 years. Treated bleeds, which is pretty remarkable. All bleeds, including small bleeds that weren't treated, 3.2 per year. Treated spontaneous bleeds, 0. Treated joint bleeds, 0. So this is an average of 58 weeks, a little over a year treatment. Pretty remarkable. And if you look at the circle on the right, 76.9%, over 3/4 of the patients had 0 treated bleeds. This is a very remarkable, even for hemophilia without inhibitors, let alone inhibitor patients. The next slide, still from the Haven 2 study. So this shows a group of patients, a subgroup of patients who had been on involved in a lead-in study before they started the Emicizumab prophylaxis to show the comparison in time. How did they do before they started Emicizumab compared to how they do after they started Emicizumab? The first 15, numbers 1 to 15, are children who had been on prophylaxis with bypassing agents. Remember, both Dr. Carcao and I have already said that prophylaxis with bypassing agents is not very good. So these 15 children had been on prophylaxis with bypassing agents, 12 of them with FIBA, 3 of them with niastase. And the blue bars show their bleeding rates during the period when they were on prophylaxis with bypassing agents. One of those children, number 6, looked very good. He didn't have any bleeds in either treatment, which is great. But the others basically had between, say 9 and 45 bleeds per year. A very big number of bleeds, despite being on prophylaxis with bypassing agents. Those are the blue bars. How many bleeds did they have on Emicizumab? Well, those are the yellow bars, and you don't see much yellow there at all. Numbers 1, 2, 3, and 4, I guess 1 through 5 have very small numbers of bleeds on Emicizumab, between 1.17 and 0.56 per year. And numbers 6 through 15 had no bleeding at all on Emicizumab. So this is sequential treatment, prophylaxis with bypassing agent for the first period, prophylaxis with Emicizumab for the second period. Pretty huge differences. The last 3, numbers 16 through 18, these were 3 children who had been on that lead-in study but had episodic treatment rather than prophylaxis with the bypassing agent. And none of them had any bleeds on Emicizumab. And finally, the next slide, I think this is my last data slide. Dr. Carcao showed you and spoke about the need for central venous access devices, portacaths or other central venous devices, which are needed when you're either on episodic treatment or ITI or prophylaxis with bypassing agents because of the need for intravenous treatment. Well, the patients on Emicizumab in the Haven trial did so well with subcutaneous treatment that they rarely needed, the bleeding rates, you saw how low they were, so they rarely needed intravenous treatments. So of the 43 of them who had central venous access devices, 22 of them could be removed during the course of the study. So that is really a remarkable outcome. So that's my last slide, and I thank you for your attention.
Thank you, Jerry. And now we're very happy to have you on board, Vanessa, and please step forward.
Thanks, George.
Hello.
I'm just waiting for my slides.
Michel, are you there? Yes, he is. Okay. No decision.
Is it my turn or is it Vanessa's turn? I think, yeah.
This
okay.
is Vanessa's turn.
Okay.
If Michelle can find her slides. Michelle, are you there? Yeah, here it is. Yeah, this is it. Okay, Vanessa, we're very happy to have you. Please go ahead.
Thank you. Thank you, CHS, for the opportunity to talk to you guys about practical tips with regards to Hemlibra use and administration. So I'm the nurse practitioner at the Hospital for Sick Children in Toronto. Next slide, please. So this is just an illustration of the differences between factor VIII and Hemlibra. So as you're well aware, factor VIII products that we have currently have a half-life of less than 24 hours. So patients have to frequently inject to sustain their factor VIII levels. And as we look at the levels for Hemlibra, if you can see in the graph to your right, it illustrates a half-life that is much longer, of greater than 26 days. So as you can see, the dosing for Hemlibra is much significantly decreased in comparison to the amount of times that we have to inject our factor VIII therapy. Next slide, please. So the schedule for Hemlibra is quite easy to follow. So for a loading dose, patients need to have a loading dose of 3 milligram per kilo weekly for the first 4 weeks, for 1 month total, where they were given a subcutaneous injection, which is into the fat tissue. Then after the 4 weeks, there's we decide upon an actual schedule. So whether patients would go on weekly injections every 2 weeks or every 4 weeks. And this is dependent upon the patient weight and the vial sizes that are available, as well as the preference with your clinician and the family. So maintenance dose would be half of loading, which is 1.5 milligram per kilo. Next slide, please. So this is just to give you a visual of what the schedule would look like. So for the first 4 weeks, everyone would have the same schedule. So weekly injections to ensure that you have a therapeutic drug level. And then after your loading doses, go to maintenance dose options. And this is the options I talked about, which would be weekly, every 2 weeks, or every 4 weeks. And as you can see, the dosing increases depending on the increase of the frequency, or decreasing of the frequency. So we would have 1.5 milligram per kilo if it was weekly, doubling if it was every 2 weeks, and then tripling if it's every 4 weeks. Next slide, please. This is more of a demonstration to show you that the injections a patient would receive if they were on Hemlibra once weekly in the green, every 2 weeks in the blue, every 4 weeks in the yellow, and then to compare to our factor VIII IV access would be the standard half-life factor VIII every 2 days, or an extended factor VIII, which could be up to every 4 days. Next slide, please. So this is just to show you the different vial sizes that are available for Hemlibra. As you can see, 3 of those vial sizes are the same concentration. So they're 150 milligram per mil. The difference is the actual amount that you would be injecting. So 0.4 mils, 0.7 mils, or 1 mil total. The smallest vial is a 30 milligram vial, and this is used more for your very tiny patients. Next slide, please. And as you can see, as I mentioned, a lot of patients, the schedule that they will go on will depend upon the actual weight of the patient. And the reason for this is we try to avoid wastage as much as possible. Next slide, please. So how is Hemlibra given? Most of you are well aware of how factor VIII is given by intravenous, so directly into the vein, where Hemlibra is actually less difficult to do, as it is just in a subcutaneous layer or into the fat. So as you can see in the picture to the left, it shows the pinching of the skin to bring up the fat tissue, and then going in a 90-degree angle to hit within the fat. So you're injecting into the fat, not into the muscle. So how do we give it? We properly use aseptic techniques, so clean the skin prior to injection. We would warm the vial, so make sure the medication was at room temperature prior to injecting. And common sites that are used are the abdomen, thighs, and outer upper arms. Alternative injection sites, we say alternate injection sites to reduce any reactions that can occur. Don't administer in areas that are potentially had a reaction, so red or bruised or tender or hard, or may have moles or scars. And then if you are giving other medicines subcutaneously, we say use different injection sites. Should they have a reaction, we'll know which medication it was. And when you're drawing up the medication, you use an 18-gauge transfer needle. And when you give the medication, you use a very small gauge, which is a 26-gauge injection needle. Next slide, please. This is just to illustrate the differences between factor VIII and subcutaneous Hemlibra. So for factor VIII products, all products will need to be reconstituted, where Hemlibra is already reconstituted for you. So it's in liquid form. In factor VIII, we teach families not to waste any factor VIII or even bypass agents, where in Hemlibra, we try not to waste. However, sometimes we do need to waste. Storage for factor VIII products, some require refrigeration, some are able to stay at room temperature for up to 6 months, where Hemlibra is required to be stored in the fridge, however, can have a 7-day maximum of being at room temperature. For factor VIII products, we usually use the same IV access site, where Hemlibra, we would rotate injection sites. Assessment for factor VIII products, we'd assess the site for venous access, so what would be your best veins to use. In Hemlibra, we do an assessment just for a subcutaneous injection site. And for factor VIII products, venous access devices may be used, such as PICC lines or portacatheters, or direct intermittent, so using a vein intermittently for all injections. And then for Hemlibra, sub-Q injection. Next slide, please. The possible side effects of a subcutaneous injection really could be for any subcutaneous injection, not necessarily just for Hemlibra, but for the purpose of this presentation, you may have bruising from having a poor technique or a dull needle. So making sure that you're pinching the skin up and rotating sites, and you're always using a new needle every injection. For pain, you may have a poor technique as well, or a dull needle, or the medication may be cool. So always remember to have the medication at room temperature prior to injection. So usually for 15 minutes out of the fridge should suffice. Ensure that the alcohol that you're using to clean the skin is dry prior to the injection. Ensure that your needle is not bent from when you remove the cap. And you want to penetrate the skin quickly and not slowly. There's question as to whether EMLA actually helps with subcutaneous injection. There's been some anecdotal reports from some clinics saying that if you leave an EMLA patch on actually longer, it actually has better effect. So using an EMLA patch for 2 hours may have better effect for those patients that require pain management. With regards to scarring, it's usually related to poor site rotation. So we say rotate your sites with each injection if possible. And if you're able to track the sites in a log, it will help you remember where you last injected. Redness or itching or pain could be just a local reaction at the injection site. So we say apply a cold compress after for a few minutes if this is what you feel, and it should improve within 24 hours. And seek medical attention if it's not improving. Next slide, please. So proper handling and storage of it, it should not be used after the expiry date. As I mentioned before, in a refrigerator between 2 and 8 degrees Celsius, do not freeze it and do not shake the medication. Protect it from light, so keep it in its box. Once it's removed from the refrigerator, unopened vials can be kept at room temperature for up to 7 days. So it can actually come out of the fridge and go back into the fridge. So if you were to travel on a day trip, you could actually take it out of the fridge in the car with you and then put it back in the fridge at night. And that would be considered 1 day out of the fridge. So you're allowed to have a cumulative storage time outside the fridge for 7 days. Next slide, please. So how do we monitor Hemlibra effectiveness? So really it's pretty much similar to how we report bleeds in factor VIII. So if a patient is feeling a bleed symptom or is unsure, we really recommend patients to be reaching out to their centers. And with not having as much experience with Hemlibra, sometimes we will bring them to clinic to diagnostically diagnose a bleed. With regards to blood work, to show the effectiveness of Hemlibra, we will do a PTT, so a partial thrombin time that looks at your clotting time. And this should be very short when we test this. And this shows that the Hemlibra is working. There's no need for factor VIII levels, as Hemlibra does not give you a factor VIII level. We can do drug levels. So for Hemlibra or Emi, what does that actually mean? There's no correlation between saying an Emicizumab or Hemlibra level of a certain number would give you a factor VIII level of a certain percentage. However, we can probably assume that patients on Hemlibra that have not missed doses should be a mild patient, probably between 15 and 25%, I would say. And if any physicians would like to comment on that later, that would be good for the discussion time. Next slide, please. So other questions regarding medical management is, are central lines still needed? So patients that previously had central lines because they're on ITI or needing frequent injections of factor VIII for bleeding episodes or even using bypassing therapy, do we still need those? In our clinic and in clinical practice, majority of our patients that are on Hemlibra have done extremely well and not had bleeding episodes. So their central lines actually have come out, and we have been managing them with their subcutaneous therapy and if need be, intravenous factor VIII or bypass therapy. When it comes to bleed treatments, as Dr. Carcao had mentioned and Dr. Teitel had also mentioned, bleed treatments are not treated with Hemlibra. They're treated by factor VIII or by bypass therapy, and typically for niastases if it's a bypass therapy. Pre-procedural coverage, we know that the studies have shown that patients have done well with no coverage of factor VIII or bypass therapy, and they've only used their scheduled Hemlibra. However, I think with more clinical experience, more clinicians will be more comfortable with not using coverage prior to procedures. We have used coverage for invasive procedures. However, going forward, I know that some centers have not. The frequency to clinic visits. So previously inhibitor patients would come quite frequently to clinic, and being now on Hemlibra, I think that the question is how frequently should they be coming? I think joint disease plays a different role now. So whether they have current joint disease, target joints, whether they have some mobility issues or need rehab, obviously that's going to bring them into the clinics more frequently. But for our patients that don't have a lot of joint disease, so our younger patients that are now on this antibody, I think we start to wonder whether we should be seeing them more as a mild patient. And this is for further discussion, I think, with more experience. And then I think one of the biggest questions as clinical people is we think about how do we maintain IV access skills for patients that previously were infusing factor VIII and now going, or bypass therapy, and now going to a subcutaneous injection and not bleeding much. So how do we ensure that they keep those skills, which is still a question many of us have. And then those patients that potentially will go on Hemlibra without having IV access skills, do we teach them IV access skills? Do we have them come to hospital for therapy should they need it if it's intravenous? So I think a lot of questions are still revolving around this point, and it's difficult to know how this will play out depending on how patients do on their newer therapy. Next slide, please. So that's it for the practical tips, and I'm happy to answer any questions once we get to the question and answer period. Thank you.
Thank you, Vanessa. Jean Saint-Louis. Jean, you're next. Thank you.
Thank you, George, and good evening, everyone. Thank you for joining us, and thank you to the Canadian Hemophilia Society for organizing this very interesting session. I hope to answer some of the questions around the issue of managing bleeds and surgery when an inhibitor patient is on Emicizumab. The next slide, please, just shows my disclosures. So we have 4 sets of questions that we will briefly go over together. First one, are you sure you're having a bleed? The second question, your prior inhibitor level, does it make a difference in how you treat your bleed or if you go to surgery? Your dose of recombinant factor 7A or APCC in case of a bleed or trauma, is it the same as it used to be before? And if you're going to have minor or major surgery, does it make a difference? Next slide. So the first question is, are you sure you're having a bleed? And this is an old dilemma, and especially in older patients who have established joint disease. So are you having arthritic pain, or is this an acute bleeding pain that requires treatment? So that remains an issue, perhaps a little bit now going towards arthritic pain and acute bleeding pain if you're on Emicizumab. Why am I saying this? Next slide, please. The data from many of the Emicizumab study, as we have seen previously, shows that patients on Emicizumab experience very few bleeds. So this here, the columns show the proportion of patients who had 0 bleed on a single-arm study that was not presented before, called the Stacy study. And if you see on the right, so 80% of patients had no treated bleeds, and 63% had no bleed at all. Then you have treated spontaneous bleeds, treated joint bleeds, and treated target bleeds. So you see that a large proportion of patients over 1 year experienced no bleed at all. Next slide. One, however, must be a little bit careful, next slide, because as you see here, so what a graph like this means is that roughly 17% of the time, patients decided not to treat their bleed. So there were some bleeds and the patients opted not to treat them. And this data also shows that half of the treated bleeds were resulted from an accident or trauma, so from some kind of injury or bump or accident. So even though spontaneous bleeds are very rare, patients did have some bleeds. Often they decided not to treat. And it's very hard to say whether it was a bleed or not a bleed, but clearly if you undergo an injury, if you have a trauma, that may be the circumstances where it's more likely that there would be a bleed. So next slide. This is a very dramatic example of it, perhaps an extreme example of a patient who was on a motorcycle and was involved in a traffic accident. So obviously he did have a bleed because he had a fractured femur, he had a ruptured spleen with severe bleeding within the abdomen and shock. So clearly Emicizumab was not enough to protect this patient from a bleeding relating to surgery. And so this case illustrates some of the points that I want to make. You see here on the left that the patient had a fairly low titer of his inhibitor at the time of this traffic accident, 2.8 unit. The patient required basically repair of the blood vessels and repair of his fractures. So these are the 2 interventions, the TAE and open reduction of internal fracture. And you see that he is bleeding quite a bit. His hemoglobin level is going down. Every time there is an arrow, he's receiving a blood transfusion. And despite receiving optimal doses of recombinant factor 7A, he continues to bleed. So he, rather than going to an alternative treatment, which is FABA, they switched him to factor 8 and were able to stabilize the bleeding, and the patient survived and did well. So basically being on Emicizumab, if you have severe trauma, you can bleed. And the effectiveness of a bypassing agent is not perfect in these cases. So let's go to the next slide. I bring up the next question that I think is important to consider is, what was your prior inhibitor level? Does it make a difference if you're on Emicizumab? So the question is, what is a Bethesda unit anyway? So let's go to the next slide. So a Bethesda unit is how we measure the strength of your inhibitor. So it's BU and not BTU, like an air conditioning machine. So one Bethesda unit is means that you have enough inhibitory antibody in your blood to neutralize 50% of normal factor VIII. If you have 5 BU, it means your blood would have to be diluted 5 times to only neutralize 50% of factor VIII. And if you have a Bethesda unit of 100, your blood would have to be diluted up to 100 times to only neutralize 50% of factor VIII. So the higher the number, the stronger your inhibitor is, the more it would be able to neutralize factor VIII. Next slide. So some patients who develop inhibitor for reasons that are unknown, their Bethesda unit titer, or the strength of their inhibitor, remains low, as you see in this orange line, whereas some other patients, right away, their inhibitor titers goes very high, and certainly anything above 10 is considered a high titer, but for practical reasons, anything above 5 makes it very difficult to overcome the effect of the inhibitor if you're going to be using factor VIII. Next slide. And you see here that when patients are exposed to factor VIII after many years, some of them are called high responder. It means that if they're given factor VIII with the big blue arrow at the bottom, some patients, their inhibitor titer will go very up. That means their inhibitor level in Bethesda unit go up, and some others seem to not respond and remain with a very low titer. Next slide. So what does it mean for me? So your inhibitor titer was probably tested by your doctor just before you were switched to Emicizumab. And if the level was less than 5, especially if it was less than 2, and that may happen because you have not been exposed to factor VIII for many years, that means that factor VIII concentrate at high doses may be the safest and most effective short-term treatment for severe bleed or in case of a very risky hemorrhagic surgery. After a few days, you may have a rapid rise in your titer, but this does not influence the effectiveness of Emicizumab. So Emicizumab is just as effective whether your inhibitor titer is high or low. Such a rise, if you have a high level to begin with, or if you have a high level to begin with, means that recombinant factor VIIa, or perhaps recombinant porcine factor VIII or APCC would now become the available choice. So in other words, some patients, they may have a window where factor VIII is useful, or they may not. But it's important for your physicians usually to know this. We'll go to the next slide. However, this is not always easy to determine. Here we have another young man who has an inhibitor. He's on Emicizumab. While he's in the country on vacation during the summer, he falls off his bike. He has a pretty bad abrasion or scratches that are bleeding a bit and a swollen wrist that might be broken. He goes to the local emergency room. The doctor in the emergency room is puzzled and wondered if he really has hemophilia. Why? Because on Emicizumab, you see that normally the bleeding time, called the APTT, would be long in hemophilia, but in Joey, because he's on Emicizumab, it's actually shorter or more normal than normal. And if the factor VIII can be measured at that hospital, it would show as if the factor VIII is in fact 4 times higher than normal because Joey is on Emicizumab. Go to the next slide, please. But in fact, if specialized tests were performed, it would show that in fact, Joey's factor VIII is really low, 1%. And it's the Emicizumab, which is giving a false reassurance to the doctor that everything is fine and the patient is not a hemophilia patient. And this could be problematic. And the same influence of Emicizumab on the way we measure factor VIII and we measure inhibitor makes it a little bit more complicated. So specialized reagents and specialized hospitals have the ability to really know what is your factor VIII level and your inhibitor level while you're on Emicizumab. But it is an important data to be aware of in case of a severe bleed or surgery. So if we go to the next slide, what dose of recombinant factor VIIa or APCC in case of a bleed or trauma, is it the same as it was before? Well, if you had APCC or FABA at home when you started Emicizumab, it was probably confiscated from you when you started. So in most centers, patients were instructed to return their FABA because, as we have said before, it's been shown that when FABA is given to someone who is currently receiving Emicizumab, it does increase the risk of thrombosis much more than it used to before, to a degree where it's considered the last resort treatment. Would only be used if everything else has failed. So if we go to the next slide, what the literature says about how to treat a bleed or how to prepare for surgery. Well, we have basically at this time more guidance article than controlled study that would confirm what are exactly the best approach or best doses. But in many hundreds of patients have been treated in the pivotal trials that led to the approval of Emicizumab. And from this data and from the practical experience of physicians and patients using the product since it's been approved, we have a pretty good idea now. So the next slide does illustrate a typical way to approach bleeding. This is a graph taken from the French guidance publication, but you see on the left side of the screen that in many cases, if the bleeding is not severe, it's probably be best to wait and watch and rest and perhaps use tranexamic acid if it's an oral bleeding or a nosebleed or perhaps a gastrointestinal bleed. However, if the bleeding is significant or severe, the first line of treatment will be recombinant factor VIIa. Second line of treatment, as you see, could be, again, factor VIII if your inhibitor level is relatively low, less than 5 BU, and only in a very rare refractory case would one very carefully resort to using APCC. Next slide. So what about if you have to undergo surgery, minor or major surgery? Does it make a difference? And here we have published literature that's been extracted from all the different pivotal trials, Heaven 1 to 4. There were together more than 100 patients who had to undergo either minor surgeries and about 24 patients who had to undergo major surgery while they were on Emicizumab. We'll go to the next slide. Basically, in cases of minor surgery, such as dental procedures or removing port or undergoing an endoscopy, such as a gastroscopy or colonoscopy, or having a joint injection, not a joint replacement, but a joint injection, or other minor procedures, most patients did not bleed, and many of them were, in fact, treated as they were on Emicizumab alone without necessarily receiving additional bypassing agents. And you see here the breakdown. So, for instance, for dental procedures, there were 42 procedures, 29 had no post-op bleeding, 9 were treated with bypassing agents before and did have some bleeds. 4 were untreated and had some bleed. So it is possible to bleed if you're undergoing even a minor procedure with no other preparation than Emicizumab alone. But again, physicians are gradually building their own experience, and depending on your past your past history and the type of intervention that is required, will be able to suggest the appropriate preparation for a minor procedure. If we go to the next slide, for major surgeries, most of them were done under the cover of a preventative extra treatment with the bypassing agents. And most of the patients did not have bleeding, but some did have bleeding. And if we go to the next slides, we see 2 different types of report that are right now in the literature. This is an example, for instance, of a US patient who had a intensive recombinant factor A7 support during major surgery. So this was a joint replacement, as you see, a knee replacement. And basically the patient received the same intensive factor 7A replacement that one would have given before the days of Emicizumab. So for a joint replacement, Emicizumab was not considered sufficient, and this patient received large, numerous doses, full dose of recombinant factor 7A without any thrombosis or microangiopathic complications. So this is very reassuring that one can undergo major surgery under the coverage of full dose recombinant factor 7A. But just as before, we knew, next slide, that surgery remains, next slide please, dangerous in patients with inhibitor. They are also not so successful reports. So again, this was a report from a very reputable group in Milan of a patient undergoing a hip replacement on Emicizumab, who was receiving factor 7A, and he bled. He had much excessive breathing, and fortunately the patient had a low titer inhibitor and was switched to factor 8. So in summary, are you sure you're having a bleed? Spontaneous bleeds are infrequent while on Emicizumab, but certainly can happen, and especially if you've had trauma. Your prior inhibitor level makes a difference, because yes, if your Bethesda unit is low, factor 8 may be the most effective and safe treatment. However, there are challenging lab issues in determining this on an ongoing basis, and it requires special tests. Your dose of 7A or APCC in case of a bleed or trauma, is it the same? APCC is a lot more risky and should not be used unless everything else has failed. And recombinant factor 7A can be used at the standard dose. Some have suggested trying lower doses first. That was the British guidance as it came out at first. And major surgery is doable, but caution remains necessary. I wouldn't say that one recommends a surgery lightly, even in the days of Emicizumab for patients with inhibitor. Thank you for your attention.
Thank you, Jean. Manuel, you're on again.
Well, thank you again. And last time the internet failed on me, so I'm going to stop my video just in case that were to happen again. So Michelle, if you can just bring up my slides. Thank you. So I'm really talking about the future, and Emicizumab is asking us to address some issues and changing the landscape. And these are 2 questions that Emicizumab is forcing us to think about. So first, will we still be doing prophylaxis with bypassing agents, either FIBA or niastase? And the second question is, will we still try to eradicate inhibitors? Next. So for the first question, I think you already know the answer. This is niastase prophylaxis. You really have to give it every day. So all of those blue little squares are needles, and that's obviously a calendar. So every single day of the year, you would have to give an injection, an intravenous injection, and you would still only not get rid of all bleeds, only get rid of maybe 50 to 70% of bleeds. So patients would do all of this and still bleed. Next. With FIBA prophylaxis, you don't need to give it quite as often. 3 times a week is sufficient. But again, you need to give it intravenously. It takes a long time to give, and it only reduces the number of bleeds by 50 to 70%. Or next, now we have Emicizumab. You can give this once a week. This is once a week, but you could also give it less than once a week. And this is given subcutaneously. You don't need to find a vein. And it reduces the number of bleeds by 90%. Next. So when you compare these 3, who would choose the bottom 2, FIBA prophylaxis or niastase prophylaxis, if you have access to Emicizumab? And the answer is nobody would choose the bottom ones. So there is going to be no role. So next, there will be no role for bypassing agent prophylaxis in the future. Of course, there may be some patients who say, well, but I'm doing well with it. And that's fine if you wanted to stay with it. But in general, I doubt very much that anybody would stay with that regimen. Next. The harder question to answer is, will we still try to eradicate inhibitors? And the answer to that is sort of, maybe, and it's really not clear. Next. So in the past, we did not want patients to have inhibitors. Why? Because if they had inhibitors, the prophylaxis that we had for them, which was bypassing agents, was not very good. And so it was much, much better to move them, to get rid of the inhibitor and be able to give them factor VIII, because that is much more effective prophylaxis. But now, as you heard from Jerry, large clinical trials, and I'm just focusing on Haven 1 and Haven 2, have shown that with Emicizumab, you can have a very low rate of bleeds. You can see those 2 numbers at the bottom. Those are annualized bleeding rates. So in adults, 2.9. Now, why 2.9? Well, adults often have joint disease already established because these are patients who've had inhibitors for many, many years. So they might still have some bleeds, or they might be having arthritis and are interpreting it as bleeds. But for children who have good joints, the bleeding rate, as Jerry told you, was 0.3. That means that on average, a patient has 0.3 bleeds per year, which means it takes 3.5 years or 3.3 years for the average patient to have 1 bleed. So that is an incredible how Emicizumab, how effective it is, particularly if you have good joints. Next. So it raises the question, why bother trying to eradicate inhibitors if you can simply put patients on Emicizumab and achieve such low rates of bleeding? However, as Jean Saint-Louis showed you, bleeds do occasionally occur on Emicizumab, as he showed you a couple bleeds, and these need to be treated. And patients on Emicizumab occasionally require surgeries. And as he showed you, doing surgery, if you're on Emicizumab with a bypassing agent, brings up a lot of much more complexity. And how do you measure how your bypassing agent is working? How do you measure what the patient's inhibitor titer is to know maybe you can switch them to factor VIII? So it requires a lot of issues. Now, next. If, however, you are successful with eradicating the inhibitor, now the patient becomes an inhibitor negative patient again. Now they can still stay on Emicizumab, but they can use factor VIII, many different brands, either a standard half-life or extended half-life factor VIII, to treat bleeds if they're on Emicizumab. This is much more convenient. It's also less expensive to use factor VIII rather than to use niastase very frequently. And the combination of Emicizumab and factor VIII has been shown to be very safe. You can give factor VIII to patients on Emicizumab, and we have not seen complications. Next. However, if you do not get rid of the inhibitor and the patient remains inhibitor positive, then to treat bleeds or for surgery, your options are very limited. We really only have recombinant factor 7A and one brand of that. And very, very rarely would we use FIBA. As Jean Saint-Louis showed you on that algorithm, it was way at the bottom, FIBA, with a lot of concerns when using it. This is, of course, treating bleeds in inhibitor-positive patients on Emicizumab with bypassing agents or doing surgeries, less convenient, it's more expensive. And it's also less effective. He showed you that that one patient dropped their hemoglobin tremendously and needed 5 transfusions. So this is not as good. And of course, you can have complications. You can have safety issues, thrombotic issues when you combine a bypassing agent with emicizumab. Next. So if instead you try to get rid of the inhibitor, then factor VIII can be used in the future to treat bleeds and do surgery, rather than relying on one bypassing agent, which may not be that effective, certainly is not convenient, and it's more expensive. Next. If you eradicate the inhibitor, then the person on emicizumab who develops neutralizing antibodies to emicizumab, we didn't really talk about that, but it has happened. It's very rare, but a patient actually develops an antibody or an inhibitor to emicizumab, and then of course they can't use emicizumab anymore. But if you got rid of the inhibitor, that person can still use factor VIII. The currently available ones, or in the future, new factor VIIIs that may last longer. Next. If you eradicate the inhibitor, patients in the future may be still eligible for gene therapy. We have not talked about gene therapy, but as it stands right now, gene therapy is not being used in patients with inhibitors. Maybe in the future that will change, but not right at present. Next. And if you eradicate the inhibitor, then patients will continue to have choice in therapies. There are many different factor VIIIs, and in the future, we may even have factor VIIIs that even last longer than the current extended half-life factor VIIIs. Next. If you so there's a lot of reasons to eradicate the inhibitor. And I would say that hemophilia experts, treaters, haven't really come to a consensus on this, but they sort of have a consensus. And most physicians would say that the eradication of inhibitors is still a desirable goal, and ITI is the only approach that currently offers this potential. Consequently, most of us will believe that all inhibitor patients, when they develop an inhibitor, should be offered at least one attempt at ITI, and that probably should happen right away after they develop the inhibitor. Although inhibitor eradication is still a laudable goal, we would like to get rid of the inhibitors, but there are patients who, for various reasons, are not able to undertake ITI. Emicizumab alone is now an option. They don't necessarily have to do ITI. Next. With the availability of emicizumab, most clinicians have less support for adding immunosuppressive therapies like rituximab. There were some questions, should we use rituximab for ITI? Probably not if you have emicizumab. In the future, patients are likely to undertake fewer courses of ITI, probably just one. We're not going to have patients who are going to have one course of ITI, then they switch to a different product and do it again, and to another product and do it again. And emicizumab can almost certainly be used concomitantly with factor VIII during ITI. So that means you can be on ITI and be on emicizumab at the same time. Obviously, somebody has to pay for it. And the emicizumab is then used to prevent bleeds. And this may allow the use of low dose or low frequency ITI. So maybe 3 days a week of ITI rather than daily, which has been our usual. But remember, that's still 3 IV injections per week for a long time, a year or 2 years. That's still a lot to ask. Next. So in the past, ITI was never a choice. We as clinicians, when one of our patients developed an inhibitor, to us it was very clear. If the patient had a high titer inhibitor, they needed to undergo ITI. We wanted to get rid of the inhibitor. Next. But now, ITI is more of a choice. Next. But remember, I showed you this earlier. ITI is not easy, and it's not always successful. ITI, if started today, November 2nd, would go on, next, for a long time. So, and this is going until next October, and that would be if you're lucky to get rid of the inhibitor in that amount of time. That's a lot of needles to ask often very young children to do. Next. And of course, they're not going to be able to do it in their hand. They can't find a vein all the time in their hand. So you have to put in a port, and that has complications. And after all of this, ITI is only successful in 60 to 70% of the time, and it takes a long time. Next. So you could avoid all that and just say, forget it. I'm not going to try ITI and just go with emicizumab. And that is an option. But if a bleed does occur, you're going to have to treat the bleed with a bypassing agent like niastase, or if surgery is to occur. Next. So it is a choice, and choices can be scary, and a lot of people are going to have to make that choice tomorrow. And we, when looking after inhibitor patients, we have to make these choices as well. And you as parents and as patients also have to do this choice. So with that, I thank you for your attention and turn it over to Georges.
Thank you very much, Manuel. I believe that before we ask Michel to, if he has any question from the audience, since we haven't done anything or said anything about hemophilia B, I have here from the attendants two questions that relate to hemophilia B, and they will be both for Jean Saint-Louis. Would you recommend treatment with fitusiran for hemophilia B subjects with inhibitors? Can you say one word or two about what is fitusiran, and would you recommend this for a subject with hemophilia B and inhibitor? Jean.
So fitusiran is a treatment, also subcutaneous, once a month. It's called an inhibitory RNA. It's a product that goes to the liver and decreases another protein in the blood called antithrombin. And by decreasing antithrombin, you rebalance the forces that are to stop bleeding and promote thrombosis in the blood. So it's an investigational drug at this point, but it appears to be quite effective. It's just that it has an unknown risk of thrombosis at this point. In patients who have factor IX inhibitor, it can certainly be effective, but it's still considered an investigational. I have myself a patient receiving this medication who has an inhibitor to factor IX, and he has done very well. However, the study, the clinical trial that is ongoing, has had a number of thrombotic complications, and recently was put again on pause for the safety committee to analyze the case to see whether to continue administering the drug. So it can be used in factor VIII or factor IX inhibitor, but in the case of factor VIII, Emicizumab has been approved and felt to be very safe. Fitusiran for now is still very much investigational.
Thank you, Jean. There is a follow-up question on this, and I suppose that you probably have already answered the question, but I still state it. Are Canadian subjects eligible to fitusiran studies?
I think in Montreal, we're the only site that is open. I believe some of my colleagues in Ottawa or elsewhere have tried to also obtain the product on a humanitarian basis, and I don't know whether they were successful. I believe there was a case in Ottawa where there was an attempt to obtain fitusiran for a young patient there with a factor IX inhibitor.
Thank
but
you,
I'm
Jean.
not sure if they were able to obtain it or not.
Thank you. Michel, do you have questions, live questions from the attendant?
Yeah, we have two questions in the chat. So the first question is, what about factor VIII to tolerate PUPs to avoid development of an inhibitor?
I suppose this should go to Emmanuel, right?
Yeah, I think the question is whether to start Emicizumab on pups, potentially to prevent inhibitor, but also to prevent bleeds. And I would say the answer is yes. If we have access to Emicizumab, now that's a big if, because right now, technically we don't, that CBS in Canada will not pay for it to be used for that reason. This is in a patient who does not have an inhibitor at the time. They are a very, very young child. But in the ideal world, I would say that, yeah, we would start patients on Emicizumab. mainly to prevent them from bleeding and to do so in a way that we don't need to do intravenous injections, which is so difficult in young children. And we would not have to put in a port. The question then is, are we using Emicizumab to also prevent inhibitor development? Remember, what Jerry was showing is that inhibitors are antibodies against factor VIII. If a patient actually never got factor VIII, they would never develop an inhibitor because they haven't received any factor VIII. However, we know that if you're on Emicizumab, you're not going to prevent every single bleed for your entire life. So at some point, the patient would require factor VIII, and then that's when a dangerous situation may arise. They may develop an inhibitor. Now, you might say, well, who cares? They're on Emicizumab. You can use it if they develop an inhibitor. And that is very true. But you might be then in a situation where you may not know if you can use factor VIII to treat them if they may have an inhibitor. But I believe that Emicizumab in pups is really the way to go, because that is the patient group that has the most difficulty with an IV injection. You know, there may be some of you on this webinar who are 30-year-olds or 20-year-olds or whatever, adults who've done thousands of needle injections in your life. You would benefit also from Emicizumab, but you can imagine how a 1-year-old child might benefit the most.
Okay. There's another question, Josh. So if the titer becomes undetectable, but the person remains a low responder, is this the non-neutralizing antibodies? If so, do these respond to immune tolerance? So Manuel, maybe?
Yeah, so
Yeah.
I think,
Yeah.
well,
Go ahead,
you know,
Manuel. Yeah.
I'll say just a few words, and then maybe Georges may say. We do know that if you have a patient with an inhibitor, and let's say it's, I don't know, 50 Bethesda units, that's quite high, and you put them on Emicizumab, and if they do well, and a year goes by, and another year goes by, and during that time, maybe they were exposed a little bit to niastase, but they never got factor VIII, ever. We know that the inhibitor titer in general will fall, and now they may have an inhibitor titer of 1 or 2. The question then becomes, if they're in a situation where they need to receive treatment other than Emicizumab to treat a bleed, could you give them factor VIII? And you probably could for a day or two, but we think that most patients would develop an anamnestic reaction. Their inhibitor titer would rise. But, you know, we don't have all the answers to patients on Emicizumab, especially for many, 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 many years. We don't know if you're on Emicizumab for 10 years or 15 or 20, maybe the inhibitor will go away. You know, we just don't know those answers. But I'll leave it to George if you want to add anything.
Well, not very much to add. Clearly, of course, if you let your inhibitor go down low enough that you can use factor VIII, this is clear, as you stated, that most patients will have an anamnestic response within a few days. Of course, if one is dealing with a life-saving situation, say an intracranial bleed, I'd still believe that I would go for the first shot or 2 or 3, as long as it will work with factor VIII. And here we have to remember that some of those patients will already be on Emicizumab, and I don't know, maybe the remaining effect of Emicizumab plus a little reduced but still effective efficacy of factor VIII, that might do it. And now, as for those patients who have non-neutralizing antibodies, are they more likely to have an anamnestic response with a neutralizing antibody? I don't know the answer for this. I know that some patients will have a non-neutralizing antibody for many years and will never develop a true neutralizing antibody. So many more questions than answered, in fact. Now, Michel, do you have any other question from the audience now?
Yeah, there's 2 more. One is more of a comment from Norman. The comparable F8 factor VIII level on Hemlibra stated was quite lower then I was advised of 40% or so, factor VIII level. So this is, I don't know if somebody wants to comment on that.
Jerry, I suppose this is your turf.
Well, if I interpret this correctly, I think what you're looking at is the question of what is the comparable factor VIII level to your protection on Emicizumab. I think that's what you're saying. And we don't really know. That's not a real number. What we're saying is that it seems that people on Emicizumab have maybe a 15, are more or less like someone with 15 to 20% factor VIII. But that's not a real number. It's an inference. We can measure. It's not easy, but there are ways of measuring residual factor VIII if you are on Emicizumab. For example, if you had an inhibitor and it's intermittent, you may, if the titer has dropped because you're on Emicizumab, maybe the factor VIII has come back. We do have ways of measuring that. They're not standard assays, they're special assays. But we assume that someone on Emicizumab is is equivalent to a mild hemophilia A patient. So I think that's what you're looking at. What is the equivalent? And it's a rough guess. It's not something that's really measured or measurable.
Thank you, Jerry. Michelle, can we go for one or two more questions from that you received recently?
Yeah, there's a follow-up question to the pups question that we discussed earlier. So
Yeah,
for those
well,
pups on Emicizumab, would you also give them factor VIII to tolerize them and avoid an inhibitor later in life?
Yeah, I guess this question is probably for me, or George, I'm sure can answer that too. I've thought about that question. I've thought about it from the standpoint, if I was the parent, or if I was the child, or if I'm the physician. As a physician, intellectually, I would like to do that. I would like to give them factor VIII on a regular basis. Now, it won't be too frequent, but maybe every 2 weeks or so. But even that is still pretty difficult. In a year, that would still be 26 intravenous injections. So more and more, as I'm thinking about it, I'm thinking it's not going to happen, not in very young children if I start a pup on Emicizumab. So the ideal world would be, yes, we would do that, but in the real world, I don't think it's going to happen. I do think, however, you can probably give factor VIII if you're doing a blood test, because you have to poke them anyway, although you don't really need to do a lot of blood tests. But maybe, at least if you expose, then you may have a little bit more control. You can just see, are they going to develop an inhibitor or not? But it's a difficult question to answer.
Yeah, maybe I should have something here, is that maybe, of course we don't know, but maybe if we leave them alone, we don't expose them to factor VIII, we keep going with Hemlibra as long as it goes, and if there is a need, well, of course, if there is a need and this is associated with an inflammatory reaction, then it is bad news for likelihood of developing an inhibitor. But maybe we might want to try to induce tolerance or expose to factor VIII later on in life. This is why I presented one of those multiple studies, but about the age of introduction of factor VIII and likelihood of development of inhibitor. And if this is true, and of course we all know these studies coming from Barcelona and the one coming from Amsterdam, they have the same observation. So it seems to be that if we introduce factor VIII later in life, the likelihood of development of inhibitor is less. I don't know if this is true, but maybe this is worth trying, instead of trying to induce tolerance where you have to poke at those poor little ones many times or several times a week maybe. So I don't know. I mean, I just throw this in the for a thought. Now, before we leave, I have two questions that I feel that I need to ask, and this one goes to Jerry. Are there any long-term side effects of Hemlibra? A tough one.
Well, I guess the easy answer is to say we haven't been using it for a long time, so we don't know the long-term side effects. There are a small number of patients who have developed anti-drug antibodies against the Hemlibra. That number seems to be very small, and I'm not aware that it has increased. And you know, people are looking now at registry data to look at the death rate of patients on Emicizumab. We don't know how that's going to play out. I think the answer is that we have not seen long-term side effects. Hemlibra is an IgG molecule. It's a natural protein that's found in the blood. It's a humanized monoclonal antibody. So there's no infectious risk. As far as I'm aware, and maybe others, Jean or Manuel might comment, but I'm not aware of other long-term side effects other than the potential for anti-drug antibodies.
Maybe for the last one of the evening, the toughest one to anyone who wants to venture on it, is there any special risk in using Hemlibra in a patient with COVID-19? Open to anyone, a brave one. I mean, I don't know myself, but I somehow I feel that, you know, you're dealing with someone with high risk of thrombosis. And of course, you have aboard a Hemlibra, which is a pro-thrombotic in a way, and that this molecule is not naturally controlled as activated factor A is with protein activated protein C. There is no control for the pro-thrombotic effect of Hemlibra. So if this is added to someone who is already in a prothrombotic state, I'd be somewhat worried. What about you, friends? What do you think?
Well, Georges, this is Jerry. I agree with you, but on the other hand, if you're on Hemlibra and you develop COVID, there's nothing you can do about it. You can't take it back. The Emicizumab effect, as I said earlier, is going to be there for 3, 4, 5, 6 months. It'll still be there. So there's nothing you can do about it. If you're on Emicizumab and you're unlucky enough to have COVID-19 and unlucky enough to have thrombotic or coagulation activation, it, I guess, would be seen as an additive risk factor. I agree with you.
Well, the only thing you can probably do is introduce anticoagulant, namely heparin, sooner than you would if you were not having some prothrombotic product on board, maybe. Now, I believe in closing, I will thank Michel for organizing this interesting conference. I would certainly thank the speakers for their very informative presentations and discussion. I would also thank the attendants for the presence and for their active participation with the question that they sent in when they registered. And in closing, I'll say a good night for Newfoundland, and good evening for BC, and bonne nuit in Quebec.
Good. So I'd like to also thank you, Georges, and everybody. And if for some reason one of your questions has not been answered within the context of the different presentations, certainly feel free to write to me with a burning question that you feel has not been answered, and I can forward it to our panel, and we'll try and get back to you in writing. So thank you very much, everybody. It's been a long night. And again, thanks to our presenters and also to our industry partners for supporting us. Have a good night, everybody.
Good night, all.
Thank you.